Hello everyone, welcome to the video lecture series Narratives in Pharmacology and Medicine. I am Sanchari Vasu Malik, a research scholar from the Department of Pharmacology, Manipal College of Pharmaceutical Sciences. Hope you have liked our previous videos and subscribed to our channel on YouTube. Today we present our second video from the lecture series to be delivered by Dr. M.K. Unnikrishnan. With more than 3 decades of teaching experience, Dr. M.K. Unnikrishnan now holds the position of Professor and Head of Department of Pharmacy Practice. Dr. Unnikrishnan divides his work between various disciplines such as drug discovery, pharmaceutical education, evolution, public health, and as well as cognition. He holds a patent for having developed a novel, non-cancerogenic anti-inflammatory molecule. He is the recipient of many awards and accolades for his excellence in teaching, research from various national agencies such as Department of Science and Technology, Department of Biotechnology, and Bhava Atomic Research Center. At the same time, he is also a visiting scientist in Indian Institute of Science, Jawaharlal Nehru Center for Advanced Scientific Research, and University of Southern Queensland, and was endowed with the prestigious Dr. T.M.A. Pai Chair in Cognition. He is the author and co-author of 83 peer-reviewed articles with a Scopus H index of 21. Today, Dr. Unnikrishnan is going to talk about the known, the unknown, and the unknowable. With this introduction, may I invite Dr. M.K. Unnikrishnan.
Good afternoon. Thank you for this invitation to speak at this program, Narratives in Pharmacology and Medicine. I have something quite personal to speak about, which might be controversial, and it is mostly coming from my experience after I moved into the clinical pharmacy section, after a very long stop in the experimental pharmacology. Now, I find the biggest problem about the knowledge systems today is that it's transformed heavily from a very wholesome kind of knowledge into a fragmented kind, where we are focused on intricacies, and education and research has become more institutionalized, and it's become an institutional teamwork effort rather than individual effort. Long back, if you look at most of the research developments came with individuals contributing heavily. You can say Raman effect was Raman's almost without any great funding from the government. The Graham Bell made the telephone without any great kind of research support and so on. But that's not the way it is today. Individual inspired agenda has now been subsumed by the institutional guided agenda, and it's driven by money more than inspiration and creativity. And dissemination of information has also changed drastically from books to periodicals, too many of them, and from primary to secondary sources. And the big picture is getting confounded by conflicting reports and disguised by the bias from vested interests because there's a money involved in it. So this whole situation is different now, and as I have found, this unknowability about the reality reminds me of a little story which I keep listening to when I go home. It's about a popular Kerala poet who's no more, but the story lives on. There was a madman who used to wander about the streets endlessly muttering to himself, "I don't understand, I don't understand." Nobody cared until the madman suddenly was awakened by some divine revelation, and from that moment he began to say, "Understood, I have understood." And a passerby could not contain his astonishment. He stopped and asked, "What have you understood?" And the answer was, "I understood that I will not understand." And that is the kind of situation that I now confront, because evidence-based medicine is so crowded with information, it's so noisy, it's become a tower of Babel, and I frequently ask this question, what kind of evidence? Created by who? And for whom? And I realize that I will never understand. Science is fragmented into 1,000 reports pouring in daily, and it's like drinking from the fire hose. There are many key questions that flash in my mind as I confront the reality of today, the clinical reality of the day. Major question being, how on earth am I going to interpret the conflicting data pouring in every other day on the dubious value of statins? I'm just giving one example. There are many such examples. One representative example refers to statins. Or the hazards of cholesterol, for instance. Or the cost of making a new drug. I see a lot of numbers coming in. How can you explain the sudden surge in reports of the adverse events of any drug, not just statins, after the patent expiry has come? How will the patient ever benefit from the inherent conflict of interest between himself or herself and the healthcare system that work for profits? These are questions that keep coming in my mind when I look at the healthcare system as it is being practiced today. Now, I just read very recently a paper in the Annals of Nutrition and Metabolism, and it said that overall an inverse trend is found between all-cause mortality and total or LDL cholesterol. Mortality is highest in the lowest cholesterol group without exception. Elderly people with highest cholesterol have the highest survival rates irrespective of where they live in the world. Now this goes completely contrary to whatever we have learned and understood and has been taught in classrooms, and if this is to be taken as truth, then what about the remaining part of the story? It becomes difficult. And there's another paper in the expert review of clinical pharmacology, again a recent one, in which Harumi Okuyama has given mechanisms of how statins can cause disease, like how statins can cause coronary artery calcification, or how it can become a mitochondrial toxin, how it can induce calcification of the arteries, how it can inhibit biosynthesis of glutathione peroxidase, and how it can be probably a precipitating factor for congestive heart failure. This is a paper which has come in, not a journal to be shirked away, because the impact factor is fairly good, 2.4. And it's not one or two, it's many. And they all seem to be speaking in different voices. And the statistical deception by people on statins especially has been highlighted by Diamond in another paper in 2015. Interestingly, all these papers have come to light after the patent expiry. That's another interesting thing. How statistical deception created the appearance that statins are safe and effective in primary and secondary prevention of cardiovascular disease is the title of the paper. It's quite recent, about 2015, just last year. And our opinion is that although statins are effective at reducing cholesterol, they fail to substantially improve cardiovascular outcomes. We have described the deceptive approach statin advocates have deployed to create the appearance that cholesterol reduction is results is impressive. Outcomes through a statistical tool called relative risk reduction. So they have even coined a new method or devised a new strategy. RRR amplifies the trivial benefits of statins, and we have also described how the directors of clinical trials succeeded in minimizing the significance of many adverse events by this kind of strategies. So these are all what you read every day. And on the other hand, you find statins being treated on next to God and on a pedestal until recently. Now there's another paper, this is in Lancet. Now look at this. Now Rory Collins et al. In 2016, very recent, made a very controversial, which is completely against what I just explained to you now. The only serious adverse events by long-term statins are myopathy, new onset diabetes and hemorrhagic stroke, something they would not have agreed to before the patent expiry. Estimated incidence is about 5 of myopathy for 50,000 patient years, 50 to 100 new onset diabetes cases, and 5 to 10 hemorrhagic strokes. But at least they have agreed principles that these are possible. Exaggerated claims about side effect rates with statins may be responsible for its underuse among individuals at increased risk for CVS. Whereas the rare cases of myopathy and muscle-related symptoms attributed to statins generally resolve rapidly when treatment is stopped. Heart attacks or strokes may occur if statin therapy is stopped unnecessarily and can be devastating. This is the conclusion he makes, and this is in Lancet. Now, I find this conflicting pouring of information very dangerous and very difficult to understand. Now, to treat or not treat has become the question. A review of research involving 70,000 patients found that there is no link between high LDL and premature deaths for people greater than 60 years from CVS disease. 92% with high cholesterol lived longer. And this is just after I just explained the other paper from Lancet. Lowering cholesterol for primary serious prevention for more people older than 60 years is a waste of time. That's what a big doctor says from the University of Ireland. And this is also published in a very respected journal, BMJ Open Journal. So I have Lancet saying one thing, BMJ saying another thing. Now what am I to take as reality? I don't know. Now look at the added evidence that comes from elsewhere. There is a terrible amount of oligopoly in the clinical trials. Very few people control all the clinical trials. This is another interesting paper which was covered in M.C.O.P.S very recently again. The RCTs on diabetes drugs has been covered between 93 and 2013, and in this one decade, so 2 decades, they found that 110 authors published 1/3 of all the RCTs on diabetes drugs. And 110 authors again published a total of 991 RCTs with a median of 20 trials per author. So have they had any time to do anything except publish RCTs is what I wonder now. 91% were commercially sponsored. 75% RCTs had at least one pharmaceutical company employee as the author. Now, there is, a term super trialists have come into existence after this paper. And these 11 super trialists have given 10% of all the articles on RCTs. 9 academics and 2 pharma employees come into this group, and they were involved in 354 RCTs. Remember, 11 people with a median of 42. The burden of authorship should be distributed more equitably, says Dr. Fritz Holman, from a very respectable place. And 0.8%, less than 1% of authors were responsible for 1 in 3 RCTs on diabetes. Such a small number, providing the main evidence on a class of drugs so important as diabetes, remember, suggests serious imbalance of power. Now, relying on key opinion leaders is a strategy every salesman follows. Now, whenever you talk to somebody in pharmaceutical sales, they use this acronym KOL repeatedly, giving due emphasis to what really they can do. KOL is in heavy demand for their image and communication ability. However, the integrity of the evidence base for glucose lowering drugs might suffer from paucity of truly independent research and an over-reliance on a few authors from a few countries who have substantial conflicts of interest. This is again Fritz Holman saying. And the question is, do these prolific authors have the time to adhere to International Committee of Medical Journal Editors guidelines for authorship? Substantial contribution, they say, is required in conception, design, data acquisition, analysis, interpretation, drafting, revising the article, final approval, accountability, accuracy and integrity of the results. This is the kind of responsibility the ICMJE clearly spells out, and are we going to have this kind of possible systems here? Now, the oligopoly of RCT is very threatening. I do think speculation about how and why people do this kind of work is off target, very clear. There is a worldview that if science is paid for by a commercial interest, that is probably tainted and at least should be viewed with caution. And those people who have done that work should always be treated with suspicion of their motives. This is another very famous person speaking from the bosom of clinical trials, that is North Carolina, Chapel Hill. Mossi Angel, a very great activist who was also the editor of the NEJM, in her book, The Truth About Drug Companies, has mentioned that the pharma industry has moved very far from discovering and producing useful drugs. Now primarily a marketing machine to sell drugs of dubious benefit. This industry uses its wealth and power to co-opt every institution, including the US Congress and the FDA, academic medical centers and medical profession itself. Most of its marketing efforts are focused on influencing doctors, since they must write the prescriptions for them. So, these are all very startling information that I think you will all agree with me. And this is when you couple this with I read recently about death from medical errors. Death certificate assigns an ICD code, and which is supposed to describe the cause of death. And about 575,000 deaths were caused by medical error between 2000 to 2002. And there is no ICD code for that. that's not a disease. So a lot of these deaths are unaccounted. We don't have a reason. As per 2004 report of inpatient deaths associated with the Agency for Healthcare Quality and Research and Patient Safety Indicators in Medicare population, this is the number. Now it will translate into about 200,000 deaths a year, and if applied to all the US admissions, it's about 400,000 deaths or more. Now such kind of startling numbers make a big dent in our faith in the system. And this is what I am going through because I find it coming every day. Now why do adverse events emerge after the patent expires? This is a very interesting connection again. Now official answer from the FDA and the big pharma is that the problems with the drugs are only seen when millions begin to use it. Very valid, absolutely true. But then why are they so well timed is what I don't understand. The Lipitor, atorvastatin for instance. Now the biggest blockbuster made 125 billion in 15 years and 11 billion in a single year. This is the kind of money from a single pill by a single company. So, there's a problem with money, you see. And it was launched in 97, and when direct to consumer advertising was launched in America in a big way. If you go to USA and if you watch TV, you will very frequently come across these direct to patient advertising. And atorvastatin was the one that made the maximum out of it. And 29 people were prescribed Lipitor, and only in 2012, when the patent expired, FDA admitted to giving alerts on diabetes, liver injury and so on. There are many more examples. I don't want to waste time. Rofecoxib, alendronate, zolpidem, esomeprazole, paroxetine, they all have this pattern of adverse events emerging after patent. Paroxetine made about 2.12 billion for GSK in 2002, the year of expiry. And this was a preferred mode of treatment for PTSD. So just look at these figures and it is startling to anybody who is witnessing the systems. The might of pharma marketing is something to be reckoned with. 1 to 3 minutes with the medical representative increases brand loyal prescriptions by 16% to 52% was a study. It could be much worse in India. These are all studies abroad. Major pharmas spend twice more on advertising than R&D. And in 2007 alone, pharma spent about 15 to 16 billion on marketing, whereas the USA NIH budget for the entire 2007 was only 29 billion. So you can just imagine the kind of propaganda that goes on. Now profit ranking of pharma giants is a very, very interesting thing. I don't think these figures hold true today, but Mossi Angel said that the combined profits for 10 drug companies in the Fortune 500, but it was around 35.9 billion, were more than the profits of all other 490 businesses put together in 2002. I don't think this is true today. Probably shaken by the fall in the pharmaceutical innovation. Probably because we are not having enough innovation today. Why this sudden drop in innovation? That's another interesting thing. And I think there again the industries are to blame. Now if you look at a very interesting paper in Journal of Clinical Investigation, this is a bit old. I think it is appropriately old because that is the time when these yields started emerging. Now what Quattro Casas? Quattro Casas is not an ordinary person. He is a Wolf Award winner, which is a stepping stone to Nobel Prize many times. He won the Wolf Award for 87, I think, for his contribution in affinity chromatography. Drug discovery, he says, is drying up because marketing and finance departments control discovery programs. Scientists have less say. The stress is on predicting failure as soon as possible. And many blockbusters would have never seen the light of day if scientists did not play an active role, he says, and he gives examples, not one or two, but many. And when the cimetidine was being considered for treating gastric acidity, and he was at the helm at that time, and somebody said, who needs this H2 thing when we have such wonderful antacids? That's exactly what was the discussion in the conference tables. And Quattro Casas was involved in the drug discovery, development and marketing registration of about 40 drugs or more which include great blockbusters like zidovudine, acyclovir, bupropion, sumatriptan, salmeterol, satacrine, gabapentin, and so on and so forth, including atorvastatin. So a man of this stature definitely has something important to say. Now, if you look at the underreporting of clinical trials, that's another concern which I think you should be aware about. The trial reporting of clinical trials was downloaded by this. It was downloaded from the NEJM, this paper, and I found that the Title 7 of FDA Amendments Act 2007 expanded the legal mandate for sponsors, and statutory components took effect before 2010. The registry has about 224,000 study reports, only 23,000 display results. Okay. Now, the compliance with results reporting is very low across many sectors of clinical trial enterprise, and low compliance may be due to ambiguity of statutory requirements, and now they are now trying to change the rules so that we have a better system of reporting the clinical trials. Now, I want all this data to go in as some lessons for the students, primarily whom I want to talk to. Do not trust the printed word, even from the most important journals and reputed journals. Medical opinion is constantly changing. We must learn to question, challenge, doubt, and discuss issues with an open mind. Indian students question very little, trust and obey authority too easily. I find this a big problem in India, and we need to be doubly careful in the background that I just described now. Thank you very much.